To me, you'll notice on your program that I'm Tim Cook. I'm not actually Tim Cook, and Sophie messaged me last night to say, would I mind giving the overview talk that I gave to the launch of NAP6, the Royal College, or it's actually the RSM, in May. And you appreciate that at my advanced stage, May's a long time ago, so really I'm seeing these slides for the first time. Okay. Now, so what we already know. Well, you know all this. I would just highlight the last 2 points, though. All previous studies in all countries have shown that muscle relaxants in their experience are the most common cause, are the riskiest drugs to give. And in NAP6 we demonstrated something completely different. It's the antibiotics in the UK right now that are causing the problem. And the last point is important. Other speakers have alluded to guidelines on management and investigation, and we were really able to carry out a genuine audit of practice against published guidelines, in particular AAGBI guidelines and BSACI guidelines. So first of all, in NAP6 we needed to develop our definitions, and there's been a brief discussion about the definition of anaphylaxis and lots of different definitions. We adopted the general European, if you like, the definition of anaphylaxis, and in particular we wanted to look only at life-threatening anaphylaxis, and that is grades 3, 4 and 5, grade 5 being fatality. We needed to define perioperative because nobody's really defined perioperative, and those were the situations listed there that we included, and nothing else. And grade 3, 4 and 5 we needed to define as well, and you'll see in grade 3 there in particular the word unexpected appears. And this is a theme all the way through, unexpected hypotension. We know from work years ago that 9% of patients having a general anaesthetic develop hypotension every day. But this is unexpected severe hypotension, or unexpected severe bronchospasm, or unexpected potential or real or airway problems. Life-threatening, grade 4. How do you define grade 4? Well, we wanted to make it really simple. And so we said that grade 4, those patients who fulfill the criteria, the indications for CPR, and those are well known. Resusc Council UK and Europe have got those tapes. So we had what we believe were relatively simple and straightforward definitions at the beginning. The aims of NAP6, again, were fairly straightforward. We wanted to know what proportion of patients are referred, what are the culprits, how many suspected cases turn out to be anaphylaxis, because not all of them do, how are patients being managed, how well are they being referred, and is there any correlation between management, how it's done, and outcomes. And nobody had really looked at outcomes of perioperative anaphylaxis before. So this is slightly complex, but basically there were 4 phases. So starting top left there was a baseline survey of anaesthetists, and many of you will have contributed to this, and thank you very much, asking about their previous experience with suspected perioperative anaphylaxis, the referral pathways that they have in place, if they know what they are, their perceptions about what might cause anaphylaxis, the high-risk drugs or the low-risk drugs, and I'll talk about that in a minute, and whether they avoid any particular drugs if they can. Phase 2 was a very comprehensive survey, the first one, of allergy clinics in the UK, looking at workload, looking at investigation pathways, looking at communication with patients, and many, many other aspects indeed. And then phase 3 on the right there were 2 components. One was a survey of anaesthetic practice. So we wanted a denominator study. We wanted to know how many of which drugs were given each year, by whom, to what sort of patients. real data. So these are not data coming from the number of ampoules sold or some database somewhere or other. These are actual cases, and this was done over a staggered 2-day period and then grossed up to a year. We took very great care about how we did that. And then the second part was the allergen study. Finally, the case reports came in. We wanted case reports. I decided to start the case report date on November the 5th so everyone could remember it, and it worked very well. And I'll go through the number of case reports we received. All NHS hospitals took part. They all had a local coordinator. It was all anonymised, and we didn't know where the patients were coming from as we were looking at them. So this was the denominator study, if you like. Don't bother to read what's on the right there, but all hospitals were sent this form, and the form was filled in for each case, and 96% of NHS hospitals returned forms. We had 16,205 forms returned, which Laura put through a machine after first eyeballing them to see whether actually they were measurable or not. Thank you very much for all your hard work. And we scaled up to an annual caseload in the UK, this might surprise you, of 3.1 million anaesthetics. That's a lot of anaesthetics. You compare that with a population of 66 million, that's a lot of anaesthetics. 77% of those were general anaesthetics. The case reporting phase was done in 2 parts. Some of you may have been involved with that, via the local coordinators, and we received part A's, which were immediately after the event, which detailed what happened in the event and immediately afterwards, and part B, when the patients had been to clinic and the anaesthetist had received the clinic letter back and the information from the clinic. So, if you like, we had the whole picture. Obviously, for not all the cases reported in that year were 541 in number, and on the right there you can see that we didn't receive a part B for 125 cases. Now that's almost certainly because those patients were still waiting to be seen in a specialist allergy clinic, even though we delayed closure for 6 months to try and capture those. And I think that points quite clearly, gives a strong signal about the adequacy of allergy services with the best will in the world. So at the bottom there, we included in the final data set 266 cases. The review process was multidisciplinary, roughly third, anaesthetists, allergists, clinical immunologists, and other people with a specialist interest, including lay representation as well. 2-stage review to minimise bias, which we could go into, but there isn't time. And then the guidelines that we used, Resus Council UK, AGBI and BSACI. And we also alluded to the NICE guidelines as well as we needed to. And separately from the clinic, we went through all the results and identified where we could the culprit, separately from the clinic. Our culprits were not always the same as the clinic's culprits, and identified a probability based on set criteria. And also we looked at outcomes and the severity of adverse sequelae. So just very briefly, complex slide, don't look at all of it, but we set out diagnostic criteria in terms of certainty of our culprit before we started, and we divided the events into allergic anaphylaxis, IgE mediated, non-allergic anaphylaxis, non-IgE mediated, anaphylaxis mechanism uncertain, anaphylaxis uncertain, and not anaphylaxis. And you can see there, in order to identify a culprit with high certainty, the timeline must have been within 60 minutes of administration, evidence of mast cell mediator release, evidence of positive specific IgE, blood tests or skin tests. Okay, it was not just blood tests or skin tests, and the differential diagnosis excluded. And we needed 4 out of 4 criteria for essential, and then on the right there, 3 out of 4 criteria if it was intermediate certainty. And then we apportioned each one into definite, probable, and possible, and we presented the results for those cases which were definite and probable. So, key findings, the outcomes. 40 of these patients experienced a cardiac arrest, and actually 10 patients died. So this is serious stuff. And we had, of course, screened out the grade 1, 2 and 3, the non-life-threatening anaphylaxis. More than half the patients needed to go to critical care, 70% to level 3 care, the highest level of care. And as Sophie's mentioned, we identified independent factors that were associated with poor outcomes. What were the poor outcomes? About a third of patients had some poor outcome, mainly severe anxiety, change in mood, memory changes, or alterations in concentration, mobility, or PTSD. Small number of patients experienced an MI, acute kidney injury, new shortness of breath, but relatively small. And fewer than a quarter of the cases were reported to the MHRA. Now that's very interesting because previous UK data, of course, had really only come from the MHRA, and we now know, it's not perhaps a surprise, that MHRA reporting by anaesthetists or by the clinics, and we didn't really come to a conclusion about who should do the reporting, is appalling. It's done very, very badly. And I think that's probably one thing that needs to change, because we can't do an APSIX every year, unfortunately. So the survey of anaesthetic practice, mentioned the numbers there. There was an increase in the proportion of patients with obesity who were reported, and in elective weekend working compared with 2013 data. 3/4 of patients had seen a case of perioperative anaphylaxis during their practice, and it's perhaps not terribly meaningful, but when you calculate it, that produces a figure of 1 case per 7¼ years of practice, but averages don't really mean anything for this. Antibiotics were used in 57% of cases. It's almost 3 million administrations. That's a heck of a lot of usually intravenous antibiotics being given in a year, so it's not surprising we see anaphylaxis. Now, we did ask anaesthetists whether allergy history influenced their drug choice, previous allergy history. Not surprisingly, penicillin allergy did, but in those patients who received teicoplanin, or to a lesser extent vancomycin, allergy history, in other words, a penicillin allergy history, influenced their drug choice. So patients were being given teicoplanin because they gave a history of penicillin allergy, which was only correct in 1 in 10. So this theme about delabeling penicillin allergy is going to develop during the day. So clinical features and management, as Sophie mentioned, most of them were rapid, fluoxetine and patent blue relatively slower. This next point is very important, that skin signs were not seen at all in most of the very serious cases. They just didn't appear. And one can surmise that that's because in order to have skin signs, you need circulation through the skin. And if there's no circulation through the skin because you're having a cardiac arrest, you can't necessarily expect to see flushing or urticaria. We did discover that when cardiac compressions were indicated, in a significant proportion of cases, there was a delay. There was also a delay in giving adrenaline. And I think really that points to what we've been talking about earlier in terms of preparedness and simulation. IV fluid administration, anaesthetist to anaesthetist, was frankly awful. Not enough fluid was being given, and it was judged to be, and we were very kind, and on the panel, was inappropriate in almost 20% of cases. Nowhere near enough fluid. We had patients with no blood pressure receiving 1 litre of intravenous fluid. So there's a big take-home message there. Trigger agents, most common were antibiotics, then neuromuscular blocking agents. I'll be talking about those this afternoon. Then Chlorhex, then patent blue dye. That's how commonly they occur. That's not the same as risk per 100,000 exposures, because not all these things are administered in equal numbers. The risks per 100,000 exposures, by far the riskiest drug is ticaplanin, because that's only a drug really which can be given parenterally. It's a hospital drug. It's not a general practice primary care drug. Patent blue dye, very, very risky. Bear in mind, these were not just mild reactions, these were life-threatening reactions to patent blue dye. Then succinylcholine, then carmoxyclav. Then we come to findings from the clinic survey, from the case reports, the actual events. Average clinic waiting time was 101 days, up to 450 days, but I think that is, as I was mentioning, an underestimate, because after 6 months, some patients, quite a lot of those patients, over 100, were still probably waiting to see an allergist. Only 16% were seen within the ideal 6 weeks, ideal for skin testing 4 to 6 weeks-ish. Only 16%. A quarter pretty well breached the 18-week target on waiting times, and at least 7%, probably a lot more, waited more than 6 months. So there's strong messages to the funders and planners of allergy healthcare there. Clinic investigation complied with AEGBI guidance in about a third. That's the whole of clinical investigation, not just a skin test or a blood test, it's the whole thing. And BSACI guidance was not followed in a high proportion of cases. And the main problem was failing to test for all potential culprits, maybe not recognizing some potential culprits, again, chlorhexidine important in that, and poor communication with patients. So we had almost a couple of hundred recommendations, and I've just picked out 11, because that just seemed to be a reason why. And this is a mixed audience, so really the first 3 recommendations relate strongly to allergists and clinical immunologists. We need specialist clinics, we need more of them, greater investment, we know that. In House of Commons reports, House of Lords reports, Royal College of Physicians reports, I don't know what else you do, but we need it. The majority of the larger specialist anaesthetic allergy clinics have close involvement of an anaesthetist. We're very pleased to see that, but greater involvement is needed, especially in the smaller clinic. Diagnostic pathways are a bit of a mishmash, and I'll talk about that in relation to relaxants later on. And they do need harmonisation. So as far as anaesthetic departments are concerned, there are some departmental recommendations. Every anaesthetic department needs, however small, needs a departmental lead for perioperative anaphylaxis. It's not difficult, it's not too time consuming, but it is very, very important. It's important for training, and it's important for communication. It's also important for maintaining anaesthesia anaphylaxis treatment packs and investigation packs, and we came down very strongly in our recommendations for these packs to be available wherever an anaesthetic is given, even if that's in radiology. Perhaps you could say especially if it's in radiology. Then in terms of treatment, we could come to some fairly strong recommendations, and you'll hear the word adrenaline used more than any other today, and immediate. Get onto it quickly. I think there is an element when the wheels are falling off. You've got a patient who is succumbing in front of you. There's an element of feeling that if you give adrenaline or start CPR, you're somehow admitting to yourself that this dreadful event is actually happening in front of you. You're confirming the worst. And I believe that that may be a reason why we see delays in action, in the action that's needed. Because the whole time, at the back of your mind, you're thinking it'll get better soon. That blood pressure will go up. It's not anaphylaxis. It's not something dreadful. Don't worry. And that is delay. But the point is, if the systolic blood pressure is less than 50, there's some work showing that that patient will be pulseless with a positive predictive value of 95%. Okay, it's not perfect. 95% positive predictive value is good enough for me. So if the blood pressure falls below 50, that's measured with a non-invasive blood pressure cuff, then CPR should be started. And that, of course, was one of our criteria, or our main criteria for grade 4. Started early. No point giving intravenous adrenaline if it's not getting pumped around fast enough. And then the last two recommendations, again, are relatively strong recommendations, and they are evidenced, and that is in refractory hypotension, when all else fails, you've given adrenaline, you give more adrenaline, set up adrenaline infusion, maybe you've added noradrenaline infusion to that, you've given a whole lot of fluid, give 2 units of vasopressin. There's good evidence in refractory hypotension that it works, and repeat it as necessary. So vasopressin should be available, not necessarily in every anaesthetic room, but we should know where it is and it should be nearby. Similarly, glucagon in beta blocked patients. Beta blockade is a bad thing if you're going to have an anaphylactic reaction. Glucagon given early will help. It's not surprising because the positive effect of adrenaline depends on beta receptors, on mast cells. And if the beta receptors are blocked, you've got to find some other way of amending the balance of ADP and ATP in cells, and you need to stop calcium ingress into the mast cells some other way, and that can be done directly with glucagon. Okay, so beta blockade, give glucagon. Glucagon is readily available in pre-drawn syringes, used by diabetics. Yeah, it's freely available. You don't have to draw it up. But my belief is that glucagon should actually be in every anaesthetic room. It should certainly be in every anaesthetic pack. So I'll finish there. Thank you for listening, and I'm afraid you got some more of me this afternoon. Thank you.